Hello, everyone. A couple of different topics today, talking about intravenous NAD and ozone, and also about, oh my gosh, what was the other topic? Oh, right, about biofilms as well, and how they, biofilm disruptors and how they can be combined with chelation therapy at the same time. Just before jumping into the video, if you don't mind taking a quick moment to please like, share, subscribe, and or post a quick comment on the video, I'd really appreciate it. So thanks in advance for taking a second to do that. And as per usual, nothing I'm saying should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. So the first question was posted on a video that I posted a year ago, and it was entitled IV NAD versus IV ozone, which is better? And somebody 3 days ago asked a question, can you do these two treatments in parallel? So thank you for the question. Well, that's very much a yes/no question at the surface. There's a little more nuance to it, hence making a video about it. So when it comes to IV ozone and NAD, to my knowledge, there haven't been any research studies actually looking at whether using those two treatments in parallel. Now I'm assuming that the question is about, can you run these at the same time? Like, can you do one treatment and then do the other? I suppose if the question was, can you, do one day and one the next day, or, if you're, sort of in parallel being like part of the same treatment protocol and, one on Monday, one on Thursday or something. In my practice, like I would have no problem doing that. It's definitely, spaced out on other days. In terms of doing them actually in parallel or like in tandem with one another, I guess maybe parallel could be, one in one arm, one in the other arm, literally parallel. I'm not sure. So maybe I need more clarification with the question, but whether, if the question is, can they be run in tandem, one after the other, then again, no research literature looking at this to my knowledge, but unfortunately, there's not a whole lot of research literature looking at combining a variety of different IV types. So we just, as clinicians, sometimes have to put on our thinking caps, look at the pharmacokinetics of things and make a clinical judgment call. So when it comes to IV ozone and IV NAD, as I probably mentioned in the video, we don't really run IV NAD very often. There are some patients who do benefit from it, but I just don't really see a whole lot of clinical benefit from IV NAD, so I really don't do this in practice, but we have done it in practice. We've run both in tandem. And when we look at the pharmacokinetics of intravenous ozone, it is very, very rapidly ozone very rapidly oxidizes fatty acids and amino acids in the circulatory system. So the ozone is very rapidly degraded. It's degraded actually in the, if we're running through nature autochemotherapy, it's actually oxidizes those components in the blood in the bag of the patient's blood that's, even before it's actually run into their body. But then those ozonides, as they're called, these kind of ozone byproducts, are rapidly taken up into the cells, and they're out of the circulatory system very, very quickly. In my practice, in my clinic, I have no problem recommending IV ozone as long as it's done first, followed by the IV NAD. And because I know the ozone, even by the time the IV bag is switched over by whoever's running the IV, it's all the ozone's out of the circulatory system, so I'm not worried. It's already in the cells, so I'm not worried about the ozone, somehow oxidizing or otherwise, having a negative impact on the NAD, because just due to its nature. Now, if a patient said, oh, I want to do the IV NAD first, followed by the ozone, well, that's where I'd have some concerns, because the IV NAD, that's going to linger in the circulatory system for a significant period of time. And so what is the ozone, or the ozonides, I should say, going to do to the NAD when it encounters it into the circulatory system? And it could potentially make it not work as well, could potentially create a toxic byproduct. We just don't know, because nobody's studying these things in a formal research setting. So I think to err on the side of caution, whenever we run IVs in tandem, and ozone's one of those IVs, we run the ozone first, and then we run the other treatment, and we go from there. There are certainly IVs that, at least in clinical practice, they seem to be very safe to run. So folks will sometimes run, say, a IV nutrient bag like a Myers cocktail, and then follow that up with, say, IV NAD, and that seems to be totally fine. We don't put them in the same bag, but they seem to be totally fine, even though they're both going to linger in the circulatory system for a while. Ozone's just kind of different because it is such a strong oxidizer, and the ozonides are strong oxidizers, and we just, I have concerns about interacting with whatever's already pre-existing in the circulatory system. If it's something medicinal, we just don't want to neutralize it or have a less or damage it in some way, shape, or form. So I hope that answered the question. If not, just post again on this video or a different one, and I will get that answer the question that you were truly asking. But I think that was probably the answer, or probably the question. Just going to switch screens to the other video, or the other video, the other question there. So this is one. What was the original video called? Biofilms, best disruptors and how long they take to work. Quite a popular video for me. 1.1 or 1,100 views. Yeah, 1.1 million views. No, 1.100 or 1,000 views. But anyways, that's pretty good for my videos. So it was posted 5 months ago. And so the person 4 days ago said, in the case of a person with known high levels of mercury, arsenic, and aluminum and suspected phase 2 biofilms, would it be beneficial to use a phase 2 biofilm disruptor such as the bismuth thiol complex alongside an oral DMSA chelation protocol? Dr. Anderson, which is in reference to Dr. Paul Anderson, a brilliant naturopathic doctor from Washington State, just leading expert in the world of biofilms and almost every topic you can think of in naturopathic medicine, functional medicine. Really brilliant guy. I've been learning from him for years, and just happens to be a great human being as well. So Dr. Anderson recommends, and he developed this product called Phase 2. Oh my gosh, what is it called? Phase 2 Advanced or something like that. I can't remember what it's called off the top of my head now. Anyways, Dr. Anderson recommends the Phase 2 biofilm disruptor to be used for 4 days per week. Other protocols recommend oral DMSA chelation be done 1 day per week. Could the two protocols be combined by doing the DMSA chelation on one of the days that the biofilm disruptor is not taken? So thank you for the question. Of course, I can't give specific advice on this as mentioned earlier, but can certainly answer this or kind of address this topic academically. So yeah, there are different protocols out there, and some folks use biofilm disruptors every single day, just maybe at a lower dose, and like higher dose, say 4 days a week. With oral DMSA protocols, there are protocols out there where it might be 3 days on, 11 days off, or 1 day on, 7 days off, or some of us use IV or use oral DMSA chelation every single day, just at a lower dose. I saw a lecture once, I believe it was Dr. Joseph Pizzorno, another very brilliant naturopathic doctor, has written literally textbooks on functional medicine, naturopathic medicine, and he made a really good case for like dosing orally every single day, just at a lower dose, and that's what I've done for years. I used to do the kind of pulsed version, and just seemed to be way better tolerated, gets the metals down just as effectively. So there's different options out there. In my practice, if I had a patient where we wanted to do oral chelation therapy and in a phase 2 biofilm disrupting protocol at the same time, what I would probably do is, and I guess maybe what I have done, because I have done that before. We usually do chelation through IV, so it's just, we do lots of oral chelation too. I guess most of the cases where we're using biofilm disruptors, we're doing intravenous chelation, but just doing simple dose calculation. When it comes to Dr. Anderson's phase 2, I believe it's phase 2 advanced is the product. So it has that dithiol complex, then has black cumin seed in there in lieu of a chelating agent, because you just can't have a sort of ready to sell supplements, on the health food store shelves, or to sell online if it has a chelation agent in there. But the dosage of DMSA that's in a standard biofilm disruptor is about 100 milligrams. So if that was being used, say, every single day, then someone's going to be on, say 500 milligrams of DMSA every day, will then just modify the dose to 400 milligrams, and that should be okay. That combination of, the extra DMSA plus the dithiol complex, it might pack a bit too much oomph for someone, like they might need to actually lower down their DMSA dosage potentially. But for patients that are doing chelation and biofilm disruption at the same time, as long as we're phasing things in, then it's usually fine. Like for me, I would have them on the chelator first, and quite frankly, just the DMSA by itself might be enough of a phase 2 biofilm disruptor to cover our bases. So as I'm talking this through here, I'm thinking, oh yeah, right, that's how I do it. If I have someone who's on chelation already, we probably just don't even bother with the dithiol complex. Not that it's not a good thing to have in the mix, but if they're doing oral chelation with a higher dose of DMSA, that's probably going to be enough. But if it felt, for some reason we felt like, or I felt like we needed to have some extra phase 2 biofilm disruption in there, it just wasn't quite doing the trick, then I wouldn't personally have any reservations about phasing in that dithiol complex, but just bringing it in really slowly and just accounting for the dose of the DMSA that we already have in place. If it was back in the day when I was doing, say, 3 days on, 11 days off with the chelation protocol, then I would have it. I would certainly think about interspersing it without any reservations with chelation one day and then the more specific phase 2 disruption protocol on a different day. But again, I don't do it that way anymore. So it's. Yeah, but that's what I would do as long as the patient was tolerating it well. But again, doing the more sort of smaller dose every single day seems to be a more user-friendly way of doing the chelation. Once upon a time, it was, okay, you're going to do 3 days on, 11 days off. I'd follow with the patient a few months later. We do the follow-up. It's like, how do things go? It's like, oh man, those 3 days, not everyone, sometimes folks tolerated it just fine, but in a number of cases, they're like, oh man, those 3 days were rough. I really had to, psych myself up for those next few days because it was really rough because they're getting a much higher dose of DMSA on those days. So it seems to be much better tolerated and just as effective to take a lower dose every day. So anyways, I will leave it there for now on that. Thank you for the question again. And if anybody has any further questions on these topics, just post in the comment section below, or questions on anything else, just post below and I'll do my best to answer as soon as I can.